Hello, my name is Jay Mirchandani. I'm one of the partners at Allied Digestive Health. I'm here with Dr. Darren Brenner from Northwestern University. Thanks for coming
Pleasure. Thanks for
down
having
to
me.
this conference. Appreciate having you. So we're going to talk a little bit about irritable bowel syndrome. So yes, Dr. Brenner is from Chicago. I spent 3 years in Chicago as part of my residency. So I will ask the most important question that I'll be asking him. All right, is it Gino's, Giordano's, Malnati's, Uno? Which one is the best Chicago-style pizza?
So for us lifers from Chicago, it's none of the above.
None of the above.
Pequod's Pizza started in Morton Grove by a guy named Bert. It's in the northern suburbs of Chicago. There's now one in Lincoln Park, but its claim to fame is that its crust isn't a crust. It is basically glazed mozzarella cheese, and it is magnificent.
So I'm an East Coast guy my entire life. We won't have the conversation about New York style pizza versus Chicago
Let's go
style
pizza pie. Can we agree on that? We'll give you the pizza. We'll call ours the pie.
Fair. I will say my 3 years in Chicago did tend to gain a little bit of weight eating that pizza more than the East Coast style. But I will get back to the food conversation probably later when we talk about managing irritable bowel. But
here we go.
But first, in terms of finding out, do patients have irritable bowel? As you know, every patient comes into your office probably and says, I have IBS, my mom had IBS, my grandma had IBS, my neighbor has IBS. How do we actually know, do these patients have irritable bowel syndrome?
It's a great question because it's a subjective symptom-based disorder. Still in 2025, we don't have any major biomarkers to differentiate this from other disorders. And I think that leads to the complexity. When you look at the literature, it takes the average person 4 to 5 years to get a diagnosis of irritable bowel. And I'm going to mention this morning how to make this diagnosis in about 4 to 5 minutes.
Good.
And do it very, very accurately. But I think the problem with irritable bowel syndrome, as you mentioned, my mom had it, my grandmother has it, my sister has it, my dog has it, so I have to have it too. It comes from one of the schools of thought, which is let's just use IBS as a coverall for everything. We'll globally call everything IBS, and then we'll whittle our way down if people don't respond to therapies. And that's not what we want. So, we use the own criteria. I think most of us as gastroenterologists and even in primary care now, people are pretty familiar with these. What people have to understand is when they read the criteria, especially the most updated ones, Rome 4, they're set up for research trials, okay? Because if you look at older criteria, we used to define the abdominal symptoms, and that's a key point. You have to have some sort of abdominal component. Rome now defines it as pain. It used to be pain or discomfort. The reality of the situation is discomfort was removed from the definition because most international languages don't understand that term. But in the United States, that's how most of our patients present, right? Blah, bloating, pressure, fullness, I don't want to eat. So we have to have that piece. And I think it's a key point because I see people all the time referred for IBS who alternate between diarrhea and constipation, or they eat and they have to run to the bathroom quickly. Sure, those can be other disorders of gut-brain interaction, functional GI disorders, but it's not irritable bowel. So you have to have that pain component. You got to have shifts in bowel habits. And people will probably, or in most cases, feel better or worse when they have a bowel movement. And it's interesting. If you meet these criteria and a few other alarm signs or symptoms are ruled out, the accuracy of the diagnosis is as high as about 98%.
So, in terms of the diagnostic criteria and you probably see all these patients, they've had 17 tests and they may or may not have needed those, right? So how do you decide, who you're gonna, put through, either a colonoscopy or certain types of stool testing or blood work? How much does age play in your diagnosis and your diagnostic challenge?
Yeah, when we wrote the guideline for the American College of Gastroenterology, we used the threshold of 50. We know this is a disorder of young people, teens, 20s, 30s. Most people that enroll in their clinical trials are in their early 40s. So over 50, at the time, part of the thinking was, here's where we're at for colon cancer screening, right? So you got to do something just for colon cancer screening. I would argue now, obviously, we're down to 45. So if you're over 45, you need that colonoscopy. If there are no alarm signs or symptoms, and the common ones are, to your point, over that age threshold, bleeding or anemia, unintentional unexplained weight loss, a family history of colon cancer, celiac, or inflammatory bowel disease, or this is an acute change out of nowhere, then we really recommend the ACG, the AGA, what we call a positive diagnostic strategy. And I use this as a trick question for all of my fellows. I say to these guys, look, we're in Chicago. Chicago was built on meat packing, steaks. So if you can tell me the one test that must be done before you can treat a person who meets criteria for IBS-C, I'll buy your next steak in Chicago. And they start rattling off everything. Well, I'm not a gambler. I like to know when I'm going to win. It's a trick question. It's nothing. So on the IBS-C side, you can just go to treatment. On the IBS-D side, obviously, we recommend ruling out celiac, differentiating inflammatory bowel disease, not so much with colonoscopy anymore, but with inflammatory markers, serum CRP, fecal calprotectin. And again, if you meet the criteria, you don't have the alarm signs or symptoms, you run these tests, it's a pretty accurate diagnosis. But as you mentioned, and I know we're going to talk about, there are certainly some misses in the process.
So yeah, so in managing these patients, getting back to the initial conversation, diet, pharmacology, lifestyle, what do you recommend for your IBS patients in terms of managing them?
Great question. So the pragmatic would say you start with diet and exercise, you move your way down the spectrum from there. That should be your algorithm. But I think, you and I practice in the real world.
Yeah.
In the real world, there are different strokes for different folks. So I have people come in and they'll say, I will never take a pill. Don't even think about it. Don't recommend one. I will never take a medication. I'll think about an herbal. And then I have other people where we talk about the diet. And they say to me, I live in Chicago. I live to eat, okay? I don't eat to live. There is no way you're limiting anything from my diet. So I think first is establishing that baseline. The nice thing in 2025 is we do have multiple different interventions: food, brain gut behavioral therapies, therapeutics, natural, acupuncture, the list goes on and on. So you want to make sure you got the right diagnosis, because if you treat people, I tell people all the time, why aren't my treatment's working? I'm like, because we have the wrong diagnosis. It's treating antihypertensive with antihyperlipidemic. It doesn't work that way. So you want to make sure the diagnosis, and then I really delve into what's the quality of life aspect? What do you want to do on the spectrum of things that we have to offer? Because all of them can be good in the right person. Where do you want to start? What's the best fit? So you're right, diet. People can use fiber. They can do what I like to call FODMAP light. You don't have to do the full low FODMAP diet. Nobody should be on that long term. It's a proof of concept. There's data for the Mediterranean diet. Exercise. Exercise has always been proven to be beneficial. People say, should I exercise? And I say, unless your cardiologist or your neurologist or orthopedic surgeon says no, the answer is yes. Definitively yes all the time. You're from New York. I refer, when they're our age, to Ghostbusters. If somebody asks you if you're a god, you say yes, right? The Peter Venkman type of conversation that they had during that meeting, and people can relate to that. So I think that is a good way to start. Some people won't do it. Then you got the FDA-approved therapeutics, like I said. I am fortunate. I have 6 brain gut behavioral therapists in our division. So we do a lot of cognitive behavioral therapy, gut-directed hypnosis, and then you can get into the neuromodulators. I consider them personally in younger people in many cases, if there isn't a predominant pain component, a second-line agent, just because there is still so much stigma related to these. And so we tell people, and I talk to my patients about it, if you're going to use these, please call them neuromodulators, not the antidepressants, because we see such a high percentage of the population that have been told that this is a disorder that's all in their head. You have a good evidence-based therapy like a neuromodulator, but then they go home and they go on to Dr. Google and they type in, what is my nortriptyline, what is my amitriptyline, what is my sertraline? And it comes up antidepressant. You've lost their buy-in at that point. So it's all about the cell, but you want the person to also want the treatment that you're going to get.
Yeah, I mean, I see that a lot. Patients say, it's all, you're telling me it's not all in my head. You're giving me, these medications. Is it all in my head? Then you have that confusing
Awkward conversation, right?
Awkward conversation, right? And then it becomes tricky because you have a 25-year-old and you're putting on an antidepressant, for life. You have that tricky sort of conversation. But yeah. So and I will have to correct you one thing. I'm a Jersey guy. I've spent a lot of time in New York, but my Jersey people will
fair. My apologies to my friends in Jersey.
But I love New York as well, and as well as I love Chicago, as you see that. Great cities, all of them. But and in terms of, obviously, we talked a little bit about managing these patients. When do you start to question, do I have the right diagnosis? How do I distinguish irritable bowel from something more than irritable bowel?
And that's the hard part, right? Because we're talking about irritable bowel syndrome as a single disorder. And I don't look at it that way. I don't think a lot of my colleagues do. When I give my lectures, I talk about IBS really being an IBS-SSS phenomenon. There are multiple different mechanisms that induce the same symptoms. And right now in 2025, the nice thing is we're at that point where we can treat the totality of the symptoms. We can get that global nature of the disorder. But we still have numbers needed to treat between 8 and 12, right? We have to treat on average 10 people to get one person better because we're going after the symptom profile based on the biases of the individual and not targeting the underlying cause. So we start to think about these a little bit more. And I think this is really where history comes in. Hearing things like, I'm losing weight. shouldn't be seeing that in IBS unless somebody has overlapping ARFID and they're starving themselves because they're afraid to eat. Or I'm having nocturnal symptoms. Or I'm a 20-year-old man who's in great shape, but I have fecal urgency and fecal incontinence. I say to myself, 20-year-olds don't have fecal incontinence. So I'm looking for those tips and tricks that will make me think, well, maybe there's something in this, one of these mechanisms. We talk about SIBO, we talk about inflammatory changes, the naturopaths talk about leaky gut, bile acid malabsorption, disaccharidase deficiencies. These all play in, and we can look for the vast majority of these now, identify them, and treat to target, which I consider precision medicine with much lower numbers needed to treat, but we have to get there. So still right now, what we're telling people is this. In the vast majority of cases, it's going to be IBS. If there's an alarm sign or symptom, go after that immediately, figure it out. If you think it's IBS and they're not responding to standard therapies, maybe then it's time to go back, ask a little bit more history, see if you can tease something out or start running some more diagnostic studies. Because in the end, we are, and the data shows this, wasting billions of dollars a year in the United States on superfluous tests that we don't need to treat this disorder. And I think if we flip the script, yes, we're going to miss some people here and there. This is not a deadly disorder. It's not a terminal disorder. It may take a little longer to get there, but we can do the test after the fact, save those funds, use those funds in a much more expeditious manner, and still come up at the end of the day with the right diagnosis and the right treatment.
Yeah, no, thanks. Appreciate you taking the time out to do this, and we look forward to your talk at the general session. And thanks for coming and enjoying us. Enjoy the East Coast. Yeah, exactly. Let's go Mets. This is start of baseball season where everybody still has a chance, right? Yeah.
Wait till next year, guys.
Yeah. Thanks.